Top Med Talk.
Hi, I'm Monty Mython, Editor-in-Chief of Top Med Talk, coming to you live from the 19th Annual Duke Anesthesiology Conference, Controversies in Perioperative Medicine, in Orlando, Florida. I'm here with a friend, Stuart Grant, who's one of the co-organisers of the meeting, this being the 19th of these type of meetings, but also a colleague of ours from the United Kingdom, so back in the day. So Stuart, you've got a leadership position now. Well, you're one of the seniors at Duke, you're a professor of anesthesiology there, well known around the world for your endeavours with regards to analgesia, particularly regional analgesia and the use of ultrasound guidance. So before we get into all of that, Stuart, why did you leave us in the UK? We thought you were great.
I miss home. So I'm very lucky. I've got two homes that I love. I love North Carolina, and I miss and love training in Glasgow. The mentors I had were phenomenal. But it was one of those things. I went for a year, and they said stay. So
how long ago?
It was 1999.
Okay.
They said, "Would you stay?" My wife and I said, "Yeah, we'll give it 2 or 3 years." And of course, then it stretched and stretched and stretched, and now my kids are at college in America, and one of them's actually at Duke, and now they're Americans, and my wife and I are here. But miss the UK, but also very happy in North Carolina.
Well, there's very strong links with Duke. I mean, very different place in some ways, but very, very similar in other ways.
So when I went there, there'd been people who'd been before me, I knew, and so it wasn't a complete step into unknown. And I think it's great to have the opportunity to be able to travel abroad for a year. Things are a bit more difficult now in terms of you need the full USMLEs, all 3 parts of the exam, which is time consuming and a bit expensive, but I could say just go and do it. If you get the chance, take it. It's certainly, my plan was to take the things I learned back and do what I learned in Glasgow, and that breadth of opportunity didn't quite work out that way.
But to be fair, the vast majority, I was one of those people who went over around the similar time many years ago, and the vast majority of us went back and have done, I hope, very significant things in the NHS. I think overall there's a net gain to our system. You're always going to get people who decide to stay wherever they go. We've got mental people in London who come from elsewhere in the world.
Yeah, I think there's a net gain whenever you have that exchange of ideas. And one of the things I like about working at Duke is there still are a lot of folks come from all around and bring their ideas and exchange them with you.
And you said you were back in Scotland recently, was that right? Did a little bit of a walk?
Did the West Highland Way, and felt... Well, the first time during my time here, I felt homesick when I came back. I really had sunny weather. Not what I remember Scotland being like all the time.
You're originally from the greater Glasgow area?
I trained in Glasgow. I grew up in Ayrshire, southwest Scotland, and then trained in Glasgow and Glasgow University, and then West of Scotland Deanery.
So, geographically, that being on the western coast of the Isles over there, it does tend to be, it's a bit more Seattle-like from the point of view it's getting the weather, isn't it?
A little bit damp, yes.
So, Stuart, fantastic session this morning, great discussion, and we're just going to concentrate particularly on some elements of pain relief for providing analgesia, trying as much as possible as we can to use systemic drugs and particularly systemic opioids. We were discussing the use of particular blocks, and you had a decision-making tree, which we'll come back to, which brought you down to 3 broad categories for abdominal surgery, like the rectus sheath block, which we'll come back to, the quadratus lumborum block, which we'll come back to, and TAP blocks, which have been very popular for, I don't know what, the last decade or so, since the greater availability of ultrasound. And I think you told us originally the TAP block, to start with, was a POP block. Now, what does that mean? Well,
so it was basically a landmark technique, and it's a bit of anatomy called the triangle of Petit, and there isn't much that's petite about my patients in North Carolina. I never actually filmed this landmark. It was one of those, as soon as it was described, there was an interest in use of ultrasound, and then through a decade examination of the technique. And it's interesting because the TAP block really is a story of how we should investigate the newer blocks that are coming out. Certainly, and what we don't seem to understand completely is when we see beautiful spread from a cadaver in a cadaveric CT scanning image or a dye study, how that translates into analgesia in our patients. And those two are sometimes quite different. And the story of the TAP block was initially a wide spread, and then as time's gone on, we've sort of seen a reduction of how far and how extensive we can reliably get a spread of local regional anaesthesia.
Because when even for the pop block, when that occasionally worked extremely well, it worked really well.
Yeah.
It was something to celebrate. But
so, and I think this comes down to how we perceive our experience. And if you get a block that works, was it the block or was it the patient? There was a lovely study done years ago, and they actually gave people, as intermediate orthopaedic surgery, gave patients no analgesics whatsoever, and waited until they'd ask for pain relief in recovery. 6% of patients never asked for any pain relief. So all you need to do is have one of those 6% be your first block, and you think it's a winner. And it's interesting how we, when you get the true randomised controlled trials that come out, maybe 7, 8, I think it takes about 10 years between probably development of one of these techniques to where we really understand what its efficacy is, what the extent of the block is, and how we can best use it.
I worked with a surgeon back in the day who will remain nameless, who always did their own ankle blocks for the patients with diabetic feet.
100% success.
100%, he says. They couldn't feel anything before, and they couldn't feel anything after the block. So in part of the exploration of it, as you said, there's been people who very kindly dedicated their bodies to science. They've done experiments on cadavers, as you say, looking at the anatomical spread of the block in dead people, examined in scanners, and it can go various different places. But when they've tried to do the same in humans, and you talked about the map of TAP, I think, done in a group of pretty fit-looking Scandinavians.
Yeah,
it was all over the shop.
They all looked. I'd call them malnourished. I'd say that jealously. Very, very easy to identify. But when you actually map out dermatologically where they get a change, a sensory change, that's often very limited to some of them just around their hip joint or just above their iliac crest. Others, there was some in the abdominal wall, but this was very markedly different from those original descriptions where we're supposed to get a block from T12 to all the way up to T6.
So for those of us, the people listening to a very broad audience who aren't familiar with TAP blocks, it's this technique whereby you're putting needles in through the skin of the abdomen to identify the nerves that throughout the abdomen and getting it washed in local anaesthetic.
You're trying to get those anterior branches of the intercostal nerves that come round and supply the abdominal wall. And if we all go back to our old days in anatomy, they work their way between the layers of abdominal muscles, and we're trying to block those anterior branches and lateral perforating branches as they work their way around the abdominal wall.
So the TAP blocks become less popular, I'd say, in the same way as the epidural has become less popular under certain standards of surgery. It's still a gold standard block in many ways, but it comes with it challenges of fluid management, hemodynamic management, and prejudices about mobilisation. Abdominal wall blocks have grown in popularity, particularly with ultrasound. But there's been a movement to go more posterior, and the new kid on the block is the QL block.
Yeah, the quadratus lumborum block, and this is really stretching our anatomy, and some of it, that's a long way to remember back. But thankfully, the only book I have that's still relevant from medical school is my anatomy book.
Yeah, I've kept. There's the only one I kept.
Nothing has changed.
Samson writes physiology, because there's physiology in there people have forgotten. But you're quite right. The anatomy books are still pretty good.
And the quadratus lumborum muscle is basically the posterior part of the abdominal wall, and now people are moving further posterior to not only get the nerves there, but hopefully look at the fascial planes. These are described as fascial plane blocks, and looking to increase the spread of local anaesthetic through these fascial planes.
It says become very popular now. Every time, this is not my world, but I've heard lots of people talk about it, and I've seen the pictures, and it looks pretty compelling story to me. And I think you told us that the ASRA, which I think stands for the American Society of Regional Anesthesia newsletter recently, had, and he showed us some of the images, this artwork from the Cleveland Clinic that's open source. So you can go into the ASRA website and find all of that?
Yep.
So what do you think are the major potential benefits of it?
So the benefit compared to a TAP is hopefully a more broad spread of local anaesthetic, a more extensive block. So that is what people hoping to provide, a more extensive abdominal analgesia compared to a tap block.
And in the larger patients, I'd put myself borderline in that category when it comes to feeling my love handles around the back. Any challenges there?
So in a larger patient, well, it's always going to be more challenging with ultrasound, but it's also more challenging without ultrasound. But those are the patients where they're probably going to benefit the most from better quality analgesia. Those are the ones who want to really strive to do it. The difficult cases are the ones I think that benefit the best from any potential analgesia advantages.
And with the larger patients now, we're seeing a lot of the ultrasound's getting better and better.
Yeah.
So I'm starting to be able to see the images.
Yeah.
There are now echogenic materials being made available, so the needles are lighting up better and the catheters are lighting up better.
Yeah, so there's different costs there, but I certainly go in these larger patients. I'll opt for the more expensive, the more echogenic needle at the start in these cases. You're just trying to fight the physics. Otherwise, if the needle is going in steeply, you're not going to see it if it's not one of these better echogenic needles.
And they really light up.
They do. They do now. You have to have the technique. The needle's got to be in the plane of the ultrasound beam, so there's a bit of, if you can still do it badly, even with an echogenic needle, but hopefully it's going to make a difference for providers.
There are always some risks, and in sticking your needle in as an amateur enthusiast, you did point out that one of the landmarks is the kidney.
Yes, if straw colour fluor's dripping out and it tastes like urine, it probably is urine if that's coming out your needle. But no, the kidney's there. So it comes down to knowing your anatomy.
Yep.
I think getting used to doing these blocks in thin patients, and then you get better and better at finding the needle in obese patients. In theory it should be deeper and more well hidden in an obese patient, shouldn't it? So it should be safer. But
so, you hope so. So like all these techniques, do your homework properly, get trained well, I think your shots, don't go for the difficult shots day one.
Yeah, find your local expert, find a friend and learn on the thinner patient, I think is the moral of the story in most of these approaches.
Now, the images you showed us in your lecture, you had a patient in a lateral position doing it, as far as I could see, and different ways of sweeping. We'll come back to whether you're doing a QL 1, 2, 3, whatever it's going to come in the future. Because one of the things that seemed appealing to me for converting some of my older colleagues in particular from the epidural to the QL block, it looks as though their setup, if they sat them up, could be very similar to what they've been used to all their life, because that's part of the hurdle, is getting people to deal with all that positioning. Yeah,
so for the I'm lucky to have a block area, which is a great place to do these nerve blocks and to get things going. It lets me do it in a slow and controlled environment, not pressured, not rushed. But my technique is to sit the patients up and curl them up like I'm going to do a spinal, and I go on one flank and the other to do these QL blocks. And very often I'm back there, if I'm putting in a little bit of intrathecal opioid, a little bit of intrathecal morphine, to do the QL3 on either side. It's quite simple to do that.
There are numerous different places you can learn to do these blocks. So there are online support methods, there's textbooks, there's writing materials, but you're also doing some on healthy volunteer demonstrations this afternoon. Yeah,
we've got a workshop, and the models, one of them is my daughter, so my wife wouldn't like if we actually stuck a needle in the models. But I think there's different parts. You certainly get used to the eye-hand coordination and identifying anatomy in the workshops. An advantage of the workshop is the models are usually thinner. A disadvantage of the workshop is the more difficult imaging is not something you usually get. But you've got to learn to identify and be confident in the thin patients before you can use the imaging in the obese ones. So it depends what stage of learning you are, whether the model, with the thin model in the workshops, what you need or don't.
And do you still do these sort of preceptorship things? Can we cut you a large cheque and come and hang out for a week?
Please come and see us. And we used to do it at CME, and there were costs with that. We actually got visitors come to Duke all the time, and it's Stuart.Grant at Duke.edu. Please come and see us at Duke. We're always happy to have visitors come and watch what's going on and see how we do.
Show them direct. And your block area means that's very easy viewing.
Very easy. Yeah.
So the different QLs, just very briefly for the broader listener, why QL 1, 2, 3? Is it where you want it to end up? The target zone?
It's different groups developing it, and one of the problems with an ultrasound guided tap block is people become too anterior and they miss the lateral perforator branch. So in your flank, a branch comes off to the muscles, it runs another layer of tissue, and that's responsible for the lateral part of the abdominal wall sensation. If you don't go far enough posterior with your tap block, which is easy to do if you're doing it and somebody's lying down, then you'd miss that lateral perforator. The QL, you're going to go further posterior. It's actually the same fascial plane, but where your transverse abdominis muscle stops, your quadratus lumborum muscle begins, and you just go a little bit further posterior.
Which way do they number? Is the one the most posterior?
One's the most anterior.
Okay.
1, 2, and then 3 is the transmuscular, is the most posterior.
That's right. Because the most posterior one to me looked like where the low-hanging fruit was, if you get good at it.
So when you get in there, the only difficulty is if your needle goes too far and you put local in the psoas, this is not going to help your patients ambulate. You could get a lumbar plexus block. But certainly the other advantage about that transmuscular one is you get the splanchnic nerves. There's an ability for that to spread further up and actually go towards the sympathetic chain.
Now, we'll let you have your lunch in a second, because that's what's going on behind us here, Stuart. But is anyone leaving catheters in the QL?
Yes, we've left catheters at 1 and 2, and actually a lot of the time rather than a catheter for these blocks, in the United States we've now got a liposomal or sustained release bupivacaine formulation that can provide you prolonged analgesia. So a lot of time we're doing these blocks in patients that ambulate, and so we're putting in that liposomal formulation bupivacaine.
Got you. So that, because I know you had a mixed love affair with the liposomal analgesic things over the time of you've been testing it in different areas, gone in fashion. We haven't had access to it yet,
no.
But it sounds to us as though it would be a game changer. It sounds as though if you find the right place to put it, because it's very long acting, is it? You can get potentially even days of pain relief from it.
The days, and that's the upside. The downside thinking ahead is, what if you put it in the wrong place?
Okay.
You've then got a patient who's in pain and you can't use other local anaesthetics. So again, there's having the right skills and making sure you put it in the right place is possibly even more important with a liposomal than it is with a single shot. But yes, you're potentially you're going to get a couple of days of analgesia for this one.
So if it's you, for example, there may be someone better in the world, but there's possibility there isn't. Okay,
we can think, hypothesize.
So you think you're confident you got your needle in just the right place. You're doing a QL3 block, for example, right around the back. Would you be going for that liposomal bupivacaine and saying that's going to give me? That's what I use. And one of our fellows published at ASRA just a poster. Again, it's anecdotal experience. What we don't have yet is a good prospective randomised control trial of that versus cheaper plain bupivacaine or bupivacaine with dexamethasone added to extend the duration of the plain but. So I'm desperate for it. Now, the studies are being done. Look at clinicaltrials.gov. You can see where people are really. I think another 3-4 years we'll have a really good answer. I can definitively say, yes, this is what I'm going to use every time. You still think with these we're still at the stage of doing the sort of drug development style prospective randomised control trials with consent, or have we reached a point of possible equipoise where we could do point of care randomisation?
I think it's possible to do point of care randomisation. I think it's going to be more and more more.
We'll get closer.
But all we've got so far are traditional FDA trials where it's placebo, and that's where it's difficult to judge. And yes, it's better than saline, but is it better than another analgesic technique?
And that's the safety is high on the agenda when you're doing those trials that have got through that and it's out there FDA approved. So the final thing I'll just touch on is you had a decision tree. You said we're doing abdominal surgery is the way I took it. First question is, do you want anaesthesia or analgesia? Combination of the two. Do you want it before? Do you want it after? And then you went down the various options. And I just wanted to loop back on the rectus sheath block, because many people who are less skilled at doing taps and other blocks, they fairly reliably can hit that rectus sheath and produce some pretty impressive pain relief.
Yep, I completely agree. I think it's simple, it's superficial, it's easy to see even in obese patients, and it's got very high efficacy. So I think that's a great place to start. I think sometimes we try and make things too complex with going posterior in these tap blocks, when for midline incisions the rectus sheath is a phenomenal option.
And any use for laparoscopic surgery as well, or you're not getting the spread that covers all the ports? Or
it all depends exactly where the ports are. One of the things about laparoscopic surgery is when you have a pneumoperitoneum and you stretch those nerves, I think you get a bit of a neuropraxia, generalised abdominal pain distension, and the rectus sheath block will help for the ports, but just surgical infiltration for those ports can help.
Yes.
I think what we're missing is that sort of generalised neuropraxia.
And is that another place where the long-acting liposomal agents...
That's where the QL might prove to be, and the long-acting agent might prove to be really useful.
And for the rectus sheath, have you been using catheters or single shots and short or long-acting?
All of the above. Depending on the patient, are they anticoagulated? Do they want to leave a catheter in? Yes or no? Is there risk of infection? Be no catheter. So there's a variety of options based on the patient, their comorbidities, and where they're going afterwards.
Fantastic. Well, Stuart, thank you for spending the time with us. I hope you come back to us at the UK at some stage, maybe.
Definitely to walk and the Great Glenway is the extension of West Highland. Definitely back to do that.
You got any interest in the World Cup football at all?
Yes, I do, but it's against Scotland. I'm not qualified. I'm rooting for Iceland. So that's my new. My new team. We'll see what they do this year.
Iceland, that's where you got your money. Excellent. Now, your sporting endeavours these days are more related to field hockey, aren't they? Have you gone the other side of the stick?
I umpire, yes. Yeah. I'm now the sinister guy in the middle of the field. I umpire field hockey. My daughters play. Yeah.
Excellent, fantastic. Well, Stuart, thank you for coming here. We're looking forward to seeing your daughters later on, as you say that they're going to be subjected to some of the ultrasound exposure, but hopefully later on you can take them outside and reward them for
enjoy the sun. Yeah, thanks,
Brilliant.
Monty.
Thanks a lot, Stuart. Great to see you.
Thank you.
Top Bed Talk.